From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to this author interview from the JAMA Network. This is Dr. Adamson, the web editor for JAMA Dermatology. Hidradenitis suppurativa, also known as HS, is a common and potentially debilitating follicular skin disorder that is characterized by chronic inflammation. HS is associated with significant physical, psychological, and social impacts that can greatly impair quality of life for affected individuals. Although not an infectious disease, microbes can play a role in the disorder. And despite 2 FDA-approved drug therapies, there are few uniformly effective treatments, particularly for severe disease. In a new study in JAMA Dermatology, authors investigate the use of Intravenous Ertapenem for an average treatment course of 13 weeks for recalcitrant HS in combination with oral antibiotics, anti-androgen, and immunobiologic modulating therapies. Dr. Stephen Cohen is a dermatologist at Weill Cornell Medicine in New York City, New York. He is the senior and corresponding author of this new study, and he is here to discuss this work. Welcome to the podcast, Dr. Cohen.
Thank you, Dr. Adamson.
So glad to have you on the podcast. Can you please tell us how you got involved in HS research and a bit about your new role at Cornell?
As you said in your introduction, this very debilitated patient population, I became completely surprised and it kind of inspired by the opportunity to take care of patients that really were underserved in the most profound sense of the expression. There just really weren't, and there really isn't a standardized treatment algorithm for this disease. It's in a stage of evolution, and I like to feel that I've been part of the renaissance in patient care for hidradenitis suppurativa. When I came to Cornell, it was with the idea of expanding the program with more depth and the biomedical resources here at Weill Cornell. And I'm just in the early stages of that. But most of the patients came with me from Montefiore, Albert Einstein in the Bronx. And so I immediately started with a very busy patient schedule and a very broad, diverse patient population that had started in the Bronx and now is expanding here in Manhattan.
So it sounds like your fascination and your expertise in HS led you to this clinical problem of trying to figure out other kinds of treatments that we can pursue, particularly with patients that have recalcitrant disease. And that is not an infrequent occurrence within this patient population. And so what made you decide to pursue intravenous ertapenem as a potential therapeutic option for patients that had recalcitrant HS?
I started this effort to develop a resource for HS in 2015-16, and I realized how utterly frustrating it was to take care of patients without any sort of blueprint for treatment. And so I was reading the literature and trying to see what other people were doing. And I didn't start for several years with the development of an ertapenem treatment module. Mostly we were using oral antibiotics in various combinations that had been reported in the literature. And so the idea of using a drug like ertapenem was off my radar screen other than reading about it. But I kept on hearing great reports about it. And so I wanted to pursue this. I was completely shut down by infectious disease in our hospital, given the antibiotic stewardship programs they had. The idea of starting an antibiotic for 6 weeks that was so highly guarded was rejected. I was additionally frustrated by the fact that patients getting intravenous ertapenem need to be treated at home because it's a daily intravenous treatment. And in order to keep a line access for an extended period, you have to put in a peripheral intravenous central catheter. It's called a PICC line. And there was absolutely no one to teach me how to actually work with interventional radiology, have someone service this. and ultimately develop a relationship with home nursing services. And so all of that kind of held us up for several years before we could start. Initially, we started slowly, and we had some frustration at the outset because we used the published instructions for treatment, which was a 6-week course of ertapenem at 1 gram infusions daily. And our patients had recurrences fairly promptly after we treated them. So they got like a 6-week vacation because the drug was effective in suppressing the disease, this advanced disease where there was networks of sinus tracts and drainage and pain and debility. And so I started telling my patients, well, I'm going to give you a 6-week vacation from all of that because the ertapenem is going to completely shut down the inflammation. It'll stop the drainage and you'll feel a lot better. But I'm afraid that it's going to come back. But we could consider doing this again in the future. And I began trying different intervals of treatment. And lo and behold, as the treatment intervals got longer, beyond 6 weeks, we started to see prolonged periods of remission. Initially went from 6 weeks to 8 weeks to 12 weeks. And we ultimately settled on a treatment interval of 12 to 16 weeks, which is much longer than the published interval for HS. As I said, it was 6 weeks. And we now have remissions that go, at least 2 months, as we reported in the paper.
So I can understand how infectious disease may want to guard ertapenem as a treatment for certain disorders that are potentially lethal. It is the last line of treatment. And so if you're not necessarily used to, as a clinician, dealing with patients with HS and see how debilitating it is, you may not understand, some of the potential upside and importance for certain select patients to use this treatment modality. HS often is, I would say in general, is not considered a fatal disease, like say a rip-roaring infection in someone. So I can understand how you really got to think really hard about the potential individual benefits of using ertapenem against some of the potential public health population downsides of antibiotic resistance to ertapenem. So I could see how you had some back and forth with, and I'm sure some spirited debate with your ID colleagues about this program.
Yes, and I think there's still a lot of skepticism in the infectious disease community, and it's really difficult as we look at, kind of the pathogenesis of HS to put this in the context of the basic understanding of antibiotic use. I think we face the same thing when we deal with acne, and hidradenitis suppurativa is in that family of acne and dissecting cellulitis.
Follicular disorders.
Of follicular disorders. And, we just in terms of the antibiotic application for acne, Cutibacterium acnes is a target in acne. But in HS, we don't have that same kind of target. We have two kinds of patients. One is, a pool of patients that have, very aggressive pathogens, whether they're gram-negative or gram-positive, whether they're aerobic or anaerobic. And it's not like we have a single target. And so one of the problems we faced was, when a patient is not responding to antibiotics, where do we go? I culture every patient, every visit. And of course, I do adjust antibiotic treatment based on resistance, levels of resistance. But one of the shocking things in this study, as we look back on the data, was that, we were finding that even patients that didn't have positive cultures, but were identical in all other ways in terms of the metrics for severity of disease, were responsive to ertapenem. It's one of the things we discuss in the paper because it leaves us with a real conundrum in terms of how the drug is working. Either it's working on microbes that we are not culturing, which is possible, and that may explain why the patients respond, or there's an alternate mechanism that we don't see, that it may not, it's not a great anti-inflammatory drug, so we know it's not simply anti-inflammatory properties of the drug, but it may have a completely different mechanism that really is not well understood right now. And also, the other possibility is it may be synergistic with perhaps the anti-inflammatory therapy that we're doing. And if you want to be inhibited by the requirement to have a specific mechanism before you treat a patient, you're going to leave a huge number of patients without effective therapy. And, this is the impetus for enrolling patients in ertapenem therapy. And now I've treated probably over 200 patients, and many of them do get repeated treatments. Many of the patients actually ask for the repeated treatments. I think one of the important things that's identified in the study is that we asked the patients if they would be willing to participate in a survey afterwards. There are 98 patients in this study, and more than 75% participated in the survey. And the acceptance of this treatment is like over 80%. Patients not only felt as though it was a real life-changing therapy, but they felt motivated to tell others about it, and say, and a lot of my referrals come with patients who walk in the door and say, oh, I was in a support group and I heard about this treatment that you're doing, and they want it. Of course, we don't start there. We only treat patients with advanced disease, but it's a great way of getting patients into the system that are having a real hard time.
So I know we've had quite a discussion about some of the implications, some of the impetus around your study, but let's actually talk about the study. Now, this was a retrospective look at data from your experience in Montefiore treating about 98 patients with this treatment algorithm. You mind telling the audience what that treatment algorithm was? And secondly, how did you choose which patients? Because I'm sure you've seen way more than 98 patients with HS, between the years of 2018 and 2022. How did you select those patients?
Yeah, that's an excellent question. I implied before that we basically are using 3 different pathways of treatment. Antimicrobial therapy is only one of them. We also use anti-androgen therapy and anti-inflammatory therapy and surgery as well. And so we're dealing with patients who are not responding to any of the existing treatments. So we start with all of these other therapeutic approaches first. And of course, patients that have milder disease may not even get anti-inflammatory therapy. They may do well with oral antibiotics and anti-androgen therapy. But when we chose patients for this to enroll in this, we're dealing with patients who are refractory to treatment. There are patients who had no social life. They could not go to work, that were often, going to the emergency room for extreme pain, incision and drainage, and so forth. And so this is the patient population that we initially sought to enroll. And it was very exciting to start seeing these patients who basically were completely on the far end of the spectrum in terms of refractoriness start responding to treatment. And that's basically how we enroll the patients. So we use the HS Physician Global Assessment metric to determine severity of disease. So every patient in this is mostly has an HS-PGA, if I can abbreviate it, of 4 or 5. So they're at the most extreme end of the spectrum. More recently, we've started using the treatment for slightly less advanced disease. But again, it always depends on the patient's responsiveness to the kind of standard treatment algorithm that we have adopted. I hope that answers the question about how we chose the patients, because remember, this is a retrospective study. So as clinicians, having to face patients that are so disabled, we were looking for ways of giving them relief, short of giving them high doses of steroids or other short-term approaches that were not going to get them back into any sort of stabilized lifestyle. And so, we began using this, as I said, with the existing published treatment recommendations. And ultimately, we modified that into what has become the subject of this report.
And seems like you had a patient population that was mostly female, about 62%. And about 60% of the cohort was Black, 13% white, 3% Asian. And most of them had been on topical antibiotics. And in terms of their immunomodulatory biologic medication, 80% of them had been treated with infliximab and another 9% with adalimumab. So this is a relatively diverse cohort with bad disease that had been treated with all of the standard treatments and some treatments that were a bit more aggressive, i.e. systemic treatments with immunomodulatory medications. And then what you did is at baseline as well as mid-course and end of course, and then post-course, you measured a few variables. You mentioned one of them, which was HSPGA. You also measured pain scores. And then you looked at some laboratory values like IL-6, CRP, ESR. Would you mind telling the audience about what were, I guess, the major take-home results that they should know about the effects on these variables and treatment?
I think, number one, the efficacy of the drug is very high. As you said, these patients were...
And how are you defining that? I just want to make sure that the audience is clear on how you're defining it as the efficacy being very high.
The Hidradenitis Suppurativa Physician Global Assessment, the HSPGA, is a metric which counts and categorizes the number of abscesses, inflammatory nodules, sinus tract formation, and grades it from 0 to 5. So we were looking at HSPGA at each time point. We were also looking at the numerical rating scale for pain. Many of you probably know about the visual analog scale for pain. So we would ask a patient, if 10 is the worst pain you've ever experienced and 0 is no pain at all, how much pain do you have right now? And each time the patient would come in, we would get that metric. In recent years, which really was part of trying to follow these patients and trying to follow patients with other therapies like infliximab, we began to look for other measures that were more quantitative than the qualitative HSPGA, which has a subjective sort of quality to it, and NRS pain score. And we have been very much favoring inflammatory markers to follow how patients are responding to our treatment. So we're using SED rate, we're using CRP, we're using IL-6, and we're looking at leukocyte levels. And it's very instructive because those all improve, as they did in this study, in a very significant way when the patient is getting a good therapeutic response. I think more studies are needed to confirm that, since this is a retrospective study. But it is really hard to do prospective studies in this regard. We were motivated to do this because we had such a large cohort and we were able to study our outcomes and realizing that we had, such a positive response rate, we wanted to share this with the larger dermatology community and also our colleagues beyond. And, I think of my infectious disease colleagues because we're not trying to ignore the absolute critical importance of antibiotic stewardship. But here we have a treatment that is, pretty much the only rescue that we've found for our patients with HS. And so, we have to sort of balance these two things at this point in time.
So certainly I will agree with you that this is a potential treatment that needs further study, and perhaps the inclusion of other outcome measures may help strengthen some of the robustness. And prospective studies, both with your group and perhaps at other institutions, might help make this a potential treatment for patients that really have truly recalcitrant disease. Because as you say, we have to balance the benefits of giving this treatments at the individual level to patients to some of the potential harms and downsides related to antibiotic resistance, et cetera. But we've had to have these discussions about other disorders as well.
I think it's important to emphasize, Ade, that this patient population had very few side effects. They didn't have hospitalizations or any kind of severe complications associated with the disease. There were some, of course, adverse effects, but not a single patient was that the adverse effect did not interfere with the completion of the treatment course in a single patient. And I think that's important to emphasize, particularly as we look at this in the broader picture.
So I'm Dr. Adamson, and I've been speaking with Dr. Cohen about the use of ertapenem in the treatment of hidradenitis suppurativa. You can find a link to the paper in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Catch you on the next episode of the JAMA Dermatology podcast. Thanks for listening.